Perfect. Okay, thank you very much for that introduction. My name's Aggie McFarland. I'm a senior lecturer based at the University of Stirling from sunny Scotland, so the rain has stopped for today. I'm going to talk to you about the impact of surgical site infection and health utility values, which was a systematic review and meta-analysis that I did recently. So an overview of this presentation, I just want to talk to you briefly about surgical site infections, economic analysis, and the concept of utility, for those of you who may not be familiar with these concepts. Our research question for the review, the methods, results, and then ultimately implications. So this work was part of the ECONI study, which was a joint venture between Glasgow Caledonian University, funded by Health Protection Scotland, and my PhD, and subsequently this work was a part of that. So there's links for both of those, the study and also our research centre at Glasgow Caledonian University on the slide if you're interested. So as you know, healthcare associated infection, or HAI, are globally the most frequently reported adverse event. Surgical site infection, which I will refer to as SSI from now on in the presentation, are the most surveyed and frequent of these infections, specifically in low and middle income countries, the second most frequent HAI in Europe and the United States of America. Once developed, SSI present a significant burden in terms of excess length of stay and disability, and contribute to the development of antimicrobial resistance through the increased use of antimicrobials. Post-operative recovery is also extended if a patient has an SSI, and thus increased use of healthcare resource is required. This has implications for both morbidity and mortality, which ultimately have a significant impact on the patient's quality of life. As a result of that, obviously, prevention of surgical site infection is considered a mainstay of surgical patient care. If we're thinking about economic analysis within this context, economic evaluation are a suite of methods used to evaluate interventions and inform investment decisions in healthcare within a constrained resource context. So when I say that, it means that we have a finite budget. Cost utility analysis is a specific form of cost effectiveness analysis, whereby we measure the outcome of our healthcare through this concept called utility. And this is ideally suited to explore the economic implications of SSI prevention strategies. And because of the multimodal impact of SSI, there's no single clinical outcome measure which would adequately capture the impact of these infections. Also very, very important that we also consider the quality of life in addition to the additional life years gained. Utility allows us to do both of these things within a single measure. And if we think about utility as a valuation of health on a scale which is anchored at 0 for dead and 1 for perfect health, and it allows for a common unit of outcome for interventions which impact both morbidity and mortality, such as SSI. We can then use utility values to calculate quality adjusted life years, or QALYs, which are the standard health outcome measure used within healthcare, certainly in Europe. So our research problem when it came to this review, we know that SSI cause a significant burden, but we also know that prevention efforts are not without cost. So any prevention efforts represent an additional step of care, and therefore increases in cost either through consumables or time, whether that would be surgical time or human resource time for the extra staff activities. So there is a driver that our prevention strategies are cost effective. Current economic evaluations of SSI prevention measures are limited both in scope and quality, so there is a need for more studies in this area. Additionally, if we're thinking about how SSI impacts quality of life, such as measured in utility, there is a significant lack of this data in the current research. So therefore, we undertook a systematic review with an aim to identify and summarise a utility decrement. So how much utility is lost as a result of an adult undergoing surgery having an SSI, with a view to then informing SSI prevention investment in the future. The PICOs for the systematic review are shown on the table. So we included any surgeries in any setting and adult patients with a confirmed surgical site infection using pre-specified diagnostic criteria. Our comparator group were adults undergoing surgery with no SSI, and our outcome measures we limited to using standard validated quality of life questionnaires. So examples included the EQ5D or the SF36, which you may be familiar with. And study design was basically any study that would kind of fit within that criteria, where they were collecting quality of life at similar time points. The searches were ran in April 22. The systematic review was registered with Prospero, and the protocol, the registration acted as the protocol for this review. I've added the link in the slide if you wish to explore our methods further. So the search identified 15 studies for inclusion ranging from 2002 to 2021. Most were from the USA and the UK, and a prism of flow diagram for the systematic review is shown in the slide for information. Most of the studies looked at SSI in orthopedic surgeries involving spine and joint replacement, trauma surgeries, or a combination. And the studies predominantly focused on deep and organ space surgical site infection. Overall, the quality of the included studies was fair. Looking at the results individually from single studies, they reported utility losses associated with SSI ranging anything from 0.03 in caesarean section to 0.203 in deep SSI following joint replacement. So results from 6 studies across 7 time points were amenable to meta-analysis. And when these were combined, an estimate of utility loss as a result of SSI was 0.08. This was a range of surgeries, SSI types, and time points since surgery. So for this analysis, the I-square was moderate at 39%, and some previous reviews in this area have stated that actually the heterogeneous nature of SSI precluded meta-analysis in their review. But because our studies were predominantly orthopedic in nature, we did feel that meta-analysis was appropriate, and the I-square result kind of supports this here. We then did some subgroup analysis. Interestingly, only data relating to deep SSI were available. So we also wanted to synthesize a utility decrement for superficial and organ space, but there was not enough data in the extant evidence base. But certainly we were able to combine and have a meta-analysed estimate for deep SSI. And this showed that deep SSI reduces post-operative utility by 0.1. Over time, this reduction in utility persists. So the forest plot on the right of the slide shows the studies at the different time points since surgery. The interesting thing to note about this is that all patients experienced a drop in utility, and some of these patients were still experiencing this utility loss 12 months or more post-surgery. So what are the implications, the practical implications of what was found? So the 0.08 utility decrement found in our primary outcome for our meta-analysis does appear relatively minimal, viewed on the scale of 0 to 1 that we talked about in the very earlier slides. But if we analyse beyond this overall mean score, we can gain insight into which aspects of health are contributed to reported changes. So what we did statistics where we transferred all of our utility scores to the same utility measure, which was the EQ5D. And on the slide, you see that that is an example of the different health states within that EQ5D scoring tool. So actually, if a patient reports a 0.08 drop in an overall EQ5D utility, that could actually represent up to 2 health state dimension changes in the valuation instrument. In practical terms, that means that SSI have impacted the health of that individual to the extent that moderate, severe, or even extreme problems are now present in mobility, self-care, usual activities, or pain or discomfort. And indeed, given the prediction interval of the analysis, some patients might even experience decrements of up to 0.16, compounding this effect. The distribution of true effects of our meta-analysis indicates that 95% of patients in all comparable populations would consistently experiencing a decrement in their utility due to SSI. We must also look at this utility value decrement in the context of cumulative effects, considering the global prevalence of SSI and also the surgical volume and activities experienced globally. So small losses in quality of life when viewed across the total surgical population are potentially huge. And this finding that this decrement is present even at 12 months or more since surgery further highlights the importance of prevention efforts and investment in this area. This was the first meta-analysis of utility associated with SSI, which attempted to generate a synthesized measure of the burden of these infections on patient quality of life. So as a summary, we found an overall reduction of 0.08 of EQ5D utility, dropping further to 0.1 in patients who experience a deep SSI. The recommendations from this review include an improvement in the consistency and quality of reporting, this recommendation is driven by the fact that the data availability limited our meta-analysis to only have 6 studies from that original 15 which met the inclusion criteria. We also recommend data collection should include a full range of SSI types. As I mentioned before, our subgroup analysis was limited to deep SSI only because superficial and organ space SSI data was lacking. And given the impact of SSI persisting so long over time since surgery, we recommend future studies collect data beyond that initial post-operative period. So the results of this work are essential for infection prevention planning and future economic modelling in this field. The full review is published for open access in the British Journal of Surgery, and please take time to explore the publication, and I have added the link for our publication onto my slides. And that concludes my presentation. I'm going to stop sharing my screen.